Your pharmacology for Module 13, A, B, and D, which is your back pain. Let me find it here. Back pain, osteoarthritis, and fractures, right? Yes, A is back problems. Fractures, D is osteoarthritis, but they really all blend into each other. So starting with A and your back pain, 13A, we're going to NSAIDs. We've covered NSAIDs so many times before, and we're going to touch on them again. Your Pearson has a few places. It has a list in Module 13 on page 898 of anti-inflammatories, your NSAIDs, your antispasmodics, which are the only two sections we're going to cover. A little further over in 905, it talks about some other drugs for acute and chronic pain, Neurontin, Cymbalta, Tramadol, but I'm not going into those for this section, so I'm not holding you responsible. Back in your Module 3 comfort section of Pearson, page 157, has a section on medications where it talks about non-opioids, NSAIDs, and opioids. You may want to look over that a little bit to help with some of your information. Page 168 in Pearson has a really good section, box 3.3, categories and examples of analgesics. It goes into non-opioid NSAIDs, partial or weak opioids, mixed co-analgesics. So just helping you get more familiar with some of these drugs that we'll be talking about. And let's see, 170 on the top, table 3.4 talks about your acetaminophen content on some of the narcotics, which I've mentioned before and will mention again. Page 171, table 3.5 has an opioid-induced sedation scale for when is the point that it's not safe. I would look over that scale because you have here your, let's see, scale of 3, frequently drowsy, arousable, drifts off to sleep during conversation is unacceptable. Monitor respiratory status and sedation level closely, because this is like if you were to have a question on a PCA pump with maybe morphine, they're slightly drowsy, easily aroused, may increase opioid dosage if needed, so there was breakthrough pain, versus the description in 3 where you would make a clinical decision of not being able to increase that. Okay, so I've got some old slides that you've seen before on your NSAIDs. I think we used these in Pharm 1, I think. So you have your non-selective and your selective. Meloxicam on the bottom, or Mobic, Siloxazib on the top, or I want to say Celexa. It's not Celexa, it's your Celebrix. And you should remember your selective affects your COX-1 and your COX-2, where non-selective and your selective, just the COX-2 inhibitors, but COX-2 only inhibitors have more of a cardiac risk. Just a little picture you've seen before. 1, 2, 3, 4. That's all I can do for one day. Depends on your NSAID. Over here, where's your naproxen? Your naproxen is your over-the-counter Aleve, which is every 12 hours. Ibuprofen is your over-the-counter Motrin. Diclofenac is an interesting one. It comes in a pill form. It can also come in some other like gel and cream forms. Indomethacin is a non-steroidal, but it's used more for gout. Okay. Your NSAIDs, watching for your GI distress, dizziness, rash, heartburn, occult blood loss. Here, your 1, 2 for your NSAIDs that are twice a day, and then you're 4 times a day on some others. Your, let's see, 898 in Pearson talks about blocking the 1 and 2. Aspirin therapy is not commonly recommended for children, avoided in children. These drugs may interfere with clinical tests such as pregnancy tests, urine tests, and liver function tests. Patients should be monitored for GI distress, allergic reaction, which I mentioned. Okay, I don't know how much more I can say on NSAIDs. It hasn't been said repeatedly on NSAIDs. So to our opioids, which we just talked about in the last unit, some old slides again. The opioid analgesics relieve pain by binding to opioid receptors in the central nervous system. They are called narcotics. They act as agonists to produce the effect of analgesia. They give relief from moderate to severe pain. It's given when nonsteroidals are not enough to manage the pain. IV is the most reliable way to achieve a therapeutic response. It can be given IM or sub-Q, but the rate of absorption will vary. It is usually metabolized through the liver and excreted in the urine and the bile. You saw this slide recently on our last unit. Your hydrocodone, page 571 for acute pain. It can be given in combination with your acetaminophen. That's where this chart, sorry, you had to find it in your Pearson, page 170, table 3.4, I mentioned in the beginning. Talks about your acetaminophen content in narcotic medication, combination medication, hydrocodone, which is also your Vicodin or Lortabs, have between 500 and 750 milligrams of acetaminophen in them. So they have to be careful with your acetaminophen intake for the day. So if you're looking here and you're taking two Vicodin 4 times a day, that's 15, that's 3,000 milligrams of acetaminophen in a day. If they have 750 milligrams in their tablet, they're like Vicodin 10. Your maximum for acetaminophen in 24 hours is between 3,000 or 3,250. So you've maxed out with your acetaminophen for the day. Occasionally you will have a hydrocodone that is mixed with ibuprofen, which is not on the chart here. It's not as common. It's Rocosnod. It's, let me see, ibuprofen. It ends in a fin. I've seen a Vicoprofen. Ah, there we go. It's on your picture here. Your Vicoprofen has ibuprofen rather than acetaminophen. And your ibuprofen max for 24 hours is 2,400 milligrams. I find that one easier to remember because I think of your max prescription dosing of ibuprofen is 800. You can take it 3 times a day. 8 times 3 is 24. That's how I remember my ibuprofen max. And your acetaminophen, if you're taking extra strength acetaminophen, it's 1,000 milligrams, 2 tablets. That's 1,000 milligrams every 8 hours, and it goes out to 3,000 milligrams. 3,250 is really, but it's between 3,000 and 3,250. I find the 3,000 easier for me to remember. And keep in mind with your acetaminophen that you are watching for liver toxicity. There is a black box alert on acetaminophen for severe liver injury. Acetaminophen talks about injections. I've not seen it in an injection. It can be, but it's usually can cause significant liver damage, so it's avoided. Your ibuprofen, there's some black box warnings, increased risk of cardiovascular thrombotic events, including MI and CVA, contraindicated if they've had open heart right after, in the setting of an open heart surgery, increased risk of GI problems, which we know that with the NSAIDs, including ulceration, bleeding, and perforation. What else do you need to know here? Oxycodone, which has the Oxycontin, which is a slow release. Your morphine, MS Contin is your slow release form of it. Hydromorphone or Dilaudid, very, very potent, 5 to 10 times more so than morphine. It's very addictive. It's when other treatments have failed. I've seen it used too soon before. Fentanyl, 100 times more potent than your morphine. Here's some more pictures for you. These hydrocodone, hydromorphone, even tramadol are considered narcotic agonists, bringing on those effects. They've got your fentanyl there. This is your cough medicine that has got codeine in it to suppress the cough. You can see it comes in different forms. Your narcotic agonists, your oxycodone is the only one classified as a pregnancy B. All of these, watching caution for respiratory depression, especially in the COPD, or caution if they've had a head injury because of the central nervous system depression. Also, alcoholism due to the liver and the central nervous system depression, CVA, coronary artery disease, and hypertension, because it can elevate the blood pressure. Caution in pregnancy and lactation. Adverse effects of any narcotic is constipation. Can be nausea, vomiting. It can cause biliary spasms, leading to more vomiting. Ureteral spasms, which can lead to urinary retention. Narcotics can lead to loss of libido or sexual drive. But they can be, all narcotics can lead to a physical and a psychological dependence. You need to, time you use any type of narcotics, you have central nervous system depression, so you have to think of safety. What are safety measures? Lowering the bed down to its lowest position, having the call light in reach, monitoring the respiratory rate, making sure it's 14 or higher. You're looking for respiratory depression. Some more pictures. Here's your morphine in a sustained release tablet. Here's your PCA pump. We've talked about PCA pumps, I think, last semester. Understanding that you can do bolus doses, and you can have a PCA with a basal dose that's going continuously, boluses on top of it. They cannot overdose with it. Because it has a set dose, they can push the button like crazy. If it's not time for the dose, it's not going to give it to them. Even though they may not overdose on it, it does not decrease the risk for having a respiratory depression or adverse effect. Some Demerol, it's not used quite as often. It's giving an injection, and there's a little vial of your morphine. And you've seen this picture last semester on your Narcan, giving your naloxone. Probably familiar with that now that there's pictures all over the place for getting naloxone for free. It's a narcotic antagonist. It binds to the opioid site without activating them, causing a reversal of the opioid effects of having taken an opioid. It's given sub-Q, IM, IV, orally. Now nasal, they have it in a nasal spray. Avoiding pregnancy and lactation, cardiovascular disease, adverse effects, nausea, vomiting, anxiety, tachycardia, hypertension, tremulousness, and not listed is the anger from coming up. They come up very, 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 very fast. The next class of drugs are your antispasmodics. A muscle spasm usually results from injury causing a contraction some kind of contracture that cuts off the blood flow, increasing the lactic acid and leading to a painful spasm of that muscle. Muscle relaxants. How do they work? The majority work within the central nervous system. So again, anytime you're dealing with the central nervous system, you're thinking of safety. You're also watching possible lower dose, increased central nervous system depression in the very older, very young. Older and younger, I'll put it that way, relaxes the striated muscle. It can lead to mild weakness of skeletal muscles. It decreases the force of the muscle contraction and stiffness. That's how it helps with the muscle spasms. Muscle relaxers are used for both chronic and acute conditions or injuries. Must be very careful if they're taking it with any other central nervous system depressant, such as an opioid, which is common, alcohol, benzodiazepine, a sleeping pill, anything that is suppressing their central nervous system. Adverse effects are your lightheadedness, fatigue, drowsiness, confusion. Always think with muscle relaxers about safety measures that you would put in place and watch for. Some muscle relaxers, your cyclobenzaprine or Flexeril, methocarbamol, which is Robaxin, Tizendine or Xanaflex, metaxalone or Scalaxin. On all of these, you are monitoring for hepatic and renal function. Caution in epilepsy, muscle weakness, rheumatoid arthritis, contraindicated in pregnancy and lactation. Your methocarbamol can be given orally and by injection. And central nervous system depression, caution, also hypotension, caution. So with these, there is some herbal interactions. So for the central nervous system depression, you're looking at the interaction with St. John's wort, kava, and valerian, because those will each cause central nervous system depression, so combining that. And then there's a hypotensive potential with muscle relaxers, and the herbs that also cause that are black cohosh and hawthorn. I think it's called, yeah, hawthorn. And so combined can cause more of a hypotensive effect. With your liver enzymes, you're monitoring your hepatic AST, ALT, also monitoring your alkaline phosphatase, your renal function, BUN, creatinine clearance, and filtration rate. I'm not sure why when I wrote that, why I put that star in the Tizendine and metaxalone. I really don't know. Okay. Anything else? Teaching patients not to drive or participate in hazardous activities, other CNS depressants, allergic reactions. We do not give cyclobenzaprine or Flexeril in the pediatric population, and some of these may cause some discoloration in urine. That's enough on your muscle relaxers. One more muscle relaxer I want to talk about is your carisoprodol or Soma, which is an odd. It's used for a muscle relaxer. It's not actually classified as a muscle relaxer, but it works very well for acute muscle spasms in the elderly and those with impaired renal kidney and liver function, because it's not metabolized through those, and it's only to be used on a short-term basis. Unfortunately, it is now on that list of drugs on the street that people have become addicted to. Let's see, direct-acting skeletal muscle relaxants. Dantrolene is the drug used to prevent malignant hyperthermia that we talked about briefly over the summer. And Botox is actually another direct-acting skeletal muscle relaxant that's not absorbed systemically. I'm not going to ask you more on those. Okay, so in your fractures, Module 13B, your whole focus is on pain management. So I really didn't put any slides in there. We just covered the NSAIDs, the opioids, the muscle relaxers. The other is like blood thinners, anticoagulants, which your text talks about. We're going to get enough of that going forward when we get into the vascular, so I'm not going to add that into this section right now. So 13E, your osteoarthritis. Oh, didn't change slides. There we go. Acetaminophen, which I talked about in a previous slide when I was talking about the narcotics. It is a non-narcotic central analgesic, although at times in lots of places they listed under an NSAID. Although it is not truly an NSAID, it is a non-narcotic central analgesic. It is in your drug handbook, page 17 through 19. It's also an antipyretic. It will break a fever. Caution in severe renal impairment, alcohol dependency, liver dysfunction, contraindicated with severe hepatic dysfunction or liver disease. And there's your dose, which I mentioned, 4 grams. Actually, 4 grams in 24 hours, that's not right. It's 3,200, 3,250 in 24 hours. I need to fix that. So 3,250. Your text, the drug handbook says 4 grams, which is really too much. Topical NSAIDs, diclofenac, or comes in a topical form called Voltaren gel. It is a COX-1 and COX-2, so it's non-specific. Although it's still topical, it can still impede those prostaglandins, causing the bleeding issues. And it makes you light sensitive, not just sunlight, but also tanning beds. And to immediately report if you develop a rash. You can read more about diclofenac in your drug handbook if you wish to, starting on page 353. Okay, the last thing with osteoarthritis is cortisone injections. Your text again mentioned epidurals and things, but I'm not going that deep into it. But your cortisone injections, max of 3 to 4 injections per year. They actually do have a max. There's no written max cortisone injections in a lifetime, but they do find over a period of time it causes deterioration. So some will put a max on how many they will do, some will not, but patients should be advised of the problems and the risk of, like here, your cartilage damage, tendon weakening and rupture, and this always because they're injecting right into the joint, the bone infection. It is a cortisone. Some can be absorbed systemically when it's injected into a joint, so they can have a temporary increase in their serum glucose levels. Should be temporary. They are, if they're on any blood thinner, whether it be Coumadin, Plavix, something like that, they are to stop the blood thinner a few days prior to and hold it for a few days after injections. Of course, most of these people that are on these are seeing a cardiologist or a vascular and would have to get that approved by the vascular. That is the end of your pharmacology for Module 13.